Hello, everyone. I'm your host, Jennifer Winston, Application Specialist from Mindray Animal Medical. I'd like to welcome you to the first of 3 free Race CE webinars hosted by Probo Veterinary and Mindray Animal Medical. Just a few housekeeping notes before we get started. The webinar is recorded, and these recordings and all the webinar episodes are available at csuvetce.com for viewing by anyone, anytime, free of charge. Your microphone and cameras are disabled for the duration of the webinar, so you don't need to worry about being accidentally seen or heard. With that said, feel free to submit any questions for the speaker in the Q&A window. You'll find that window by hovering your mouse over the bottom of the Zoom screen. And I'll be asking the speaker to answer as many questions as possible after the webinar. We will also be giving away a Mindray Animal Brick set on each of our social platforms for any new follower after this webinar, so please follow us. And most importantly, I'd like to thank each of our webinar speakers. Founded in 1991, Mindray is one of the leading global providers of medical devices and solutions. Firmly committed to our mission, we employ advanced technologies and transform them into innovations adapted to various clinical scenarios. We serve over 190 countries and regions around the world with over 14,000 employees, and almost 4,000 of them are R&D engineers who explore the most advanced medical technologies. Just over 6 years ago, Mindray Animal Medical was established to solely focus on animal medical technologies, integrated R&D, manufacturing, supply chain management, marketing, customer service, and training, all in one prestigious brand. We're growing so fast that we're already building our newest global headquarters that will be completed by the end of 2027, 9 times larger than what we have today. We have 10 R&D centers around the world, with 3 of them here in the USA, Seattle, Silicon Valley, and New Jersey. And we just opened our first veterinary education center located in Finland. Our medical imaging solutions range in size, shape, and function to support all companion animals, such as felines and canines, as well as farm animals, equine, exotic animals, even lab animals for scientific research. And from the beginning of product design, we have fully considered the needs for clinical diagnosis and treatment, as well as the animal's welfare. Our transducer solutions are designed to meet the needs of large and small animals. And at the same time, diversifying monitoring accessories can be applied to the different patients while protecting their delicate skins. The Vetis 9 is the first veterinary cart-based color Doppler, and Vetis E7, the portable, equipped with the ZST platform. It opened a new era of premium ultrasound imaging to support various high-end clinical scenarios. With zone imaging technology enables ultrasound diagnosis 10 times faster than conventional line-by-line beamforming, and improves frame rate to capture real-time images of animals quicker and clearer. Zone focusing focuses on the whole image comprehensively, from shallow skin to deep organs, and the zone processing can effectively collect the original echo signal and provide more information to form a better image by using advanced algorithm. Tonight, we are joined by my friend and excellent professor, Dr. Guillaumin. Dr. G is a tenured professor in emergency and critical care at Colorado State University. And after graduating from the National Veterinary School in France, Dr. G pursued a small animal internship at the National Veterinary School of Alfort near Paris. After graduation, he worked in both private practice emergency settings and academia for several years before moving to the US in the early 2000s. Dr. G continues his advanced training in emergency and critical care by working as a clinical instructor at Cornell University, and then completed his residency at the University of California, Davis. After his residency, he was a clinician, teacher, and researcher at the Ohio State University for 10 years. There, he also acted as the blood bank director, and in 2015, he was recognized as an invited diplomat of the European College of Veterinary Emergency and Critical Care. Since 2019, he is a faculty member at Colorado State University. Welcome, and thank you all for joining.
Thank you very much, Jennifer, for the kind introduction. Thank you, everyone, for being here. And obviously, thank you, Mindray, as well, for sponsoring and helping out with this webinar. Very excited to be here again. My name is Dr. Guillaumin. I'm one of the criticalists here at Colorado State University. I've been teaching and doing point of care ultrasound for around 4 to 5 years now. This is obviously uh, a new skill that is developing quite rapidly in veterinary medicine. And I've been fortunate to be able to work on point of care ultrasound a little bit more since arriving here at CSU. So I teach several labs, and then we do have several machines as well for including some of the Mindray machines that we have. So the outline, we'll talk today about pleural and lung ultrasound, and this is the outline I created for the next 15 minutes or so. We want to talk about the ultrasound basics in a way. Not going to be too boring, but I think we need to talk a little bit about terminology, how to move the probe, those type of things. And then I want to focus a little bit more on the thoracic POCUS protocols that are available, what we see in normal point of care ultrasound. So I'm going to use the term T-POCUS, or some other people use different terminology, but I'm going to stick with the T-POCUS or thoracic point of care ultrasound. And then we will talk also in normal and abnormal. Those are also my learning objectives. And again, because I don't want to get too boring at the beginning, I'm actually going to flip a little bit and then move everything that is kind of more terminology and conventions kind of a little bit later in the program. So when you do a thoracic point of care ultrasound, or any point of care ultrasound by that matter, one of the things that is very important, at least for me, is to do your physical examination first. Point of care ultrasound is a diagnostic test, and so you want to have a history of physical examination. And then at that point, you're allowed, in a way, to grab the probe and start scanning. I do differentiate thoracic point of care ultrasound to cardiac point of care ultrasound. So to me, they're all a little bit different. We'll talk about it a little bit in the presentation, but the scanning technique is different. The questions, obviously, you're going to ask yourself are different, and the settings are also very different. So I do differentiate between thoracic and cardiac. And that's why I do like the kind of pleural and lung ultrasound terminology. But that kind of makes it all a bit more clear. We will talk about it, but to me, POCUS is really helping you to answer a clinical question. And usually it's going to be in a binary way. You know, does the dog or the cat has free fluid? Does they have a pneumothorax, or any other things that you can find on your scan? You need to be methodical in your approach to those things. And we'll talk about some of the approaches that have been published. And then you also have to recognize some of the limitations of the point of care ultrasound, especially in the chest. So I'm going to show you a little bit how I do it. Again, everybody will do a little bit differently. I will show some other ways to look into that. Usually where I'm going to start is I'm going to start in the caudal aspect of the chest. And the first thing that you're going to want to see is the curtain sign. We'll get some examples a little bit later, when you will have that pleural space over here. And when the dog takes a breath or the cat takes a breath, some of the abdominal organs are being covered by that pleura. And you can see that abdominal organs that are being covered or uncovered as the breath is being taken in and or exhaled. And so we call it a curtain sign because you kind of see a curtain onto the abdominal organs. And this is a landmark. A curtain sign doesn't mean anything specifically. There are some specific types of curtain sign that speak different things, but as a landmark, it's important. And then what I'm going to do is I'm going to slide cranially, still cotodorsal, maybe a couple of rib spaces to be able to continue to see at that kind of cotodorsal highest level of the chest. And that will be usually a very good area to look for pneumothorax. And so that will be the highest point of the thoracic wall looking for pneumothorax, and we'll talk about those type of things. Then from there, so I kind of, I'm over here, then I moved all the way, and then I'm going to go ventrally, and then we're going to look at mid-lung or perihilar, and that will be at every any of those points and all of those areas. You're going to look for different things. You're going to look for presence of B line, A lines, the glide sign, any type of pleural fluid, any shred sign, consolidation, and we'll talk about all those type of things during the presentation. So that would be kind of that my second step or third step after that cotodorsal aspect. Then I'm gonna go cranial and cranioventral, so I kind of continue on that line. And you're gonna be in the around the heart, and obviously depending of where you're gonna scan, either from the left or from the right, you're gonna see different things. The right pericardial window, the pericardial window is on the right, so if you scan on the left, you will see different things. But the main reason we're gonna do those areas is looking for free fluid. And so that free fluid is usually ventral, so you will be able to look at it. The settings will be usually too superficial to see the heart. I always recommend to switch to cardiac settings and change the depth when you are working on cardiac point-of-care ultrasound. Sometimes I will just check the heart real quick when I'm doing that thoracic point-of-care ultrasound, but you're gonna have to change the settings, change the depth, and switch to cardiac setting. The other point that you may want to look into, so then I'm over there, I'm kind of that cranioventral, and I'm gonna go a little bit cranial to the left, to the heart, or a little bit caudal to the heart, and then looking for that free fluid, again, that will accumulate ventrally. Part of the thoracic point-of-care ultrasound can include the subxiphoid view of the abdominal point-of-care ultrasound as well, and usually that would be a good one to be able to differentiate between pleural and pericardial effusion. We can talk about that all the time. So again, this is the way that I do it. There are different ways. So I call that one the checkmark sign. You can see it over here. Just gonna grab the laser point over here. So you can see it, I'm starting over here, sliding over there. So curtain sign over here, sliding over here, midpoint, and then I go over there near the heart. I'm on the left side of the dog right now. I'm gonna go cranially and caudally, looking for free fluid, and then you can go over there on that subside fluid as well. There are other protocols. Again, this one is the S protocol, and kind of similar. It has that kind of goes back over here, checking the curtain sign over there, and then going ventrally, as been described by Andrea Armanis from Italy. I believe the Calgary protocol that has been used by Dr. Boyce and Dr. Shaloub as well is over here. There is that kind of 4-square protocol that it's going to look at the 4-square, obviously cranial, ventral, and ventral, caudal, and then the dorsal aspect, both cranial and caudal aspect. And this one is an interesting one that's just going kind of following from dorsal to ventral on each of the rib spaces. It has been shown, and that kind of makes sense, that the more you scan, the more kind of stops you have in your scan, the more you're going to be able to find some abnormalities. And so, but sometimes from a technical and practical standpoint, we may just work on a 6 to 9 point on thoracic point-of-care ultrasound. So what do you see when you are putting the probe? So we'll talk again about logistic and convention, but most of the time what we're gonna do is that we're gonna put the probe with the reference point, which is my thumb over here, kind of facing cranially, and we're gonna put them transverse to the rib. So we may see something that some people call the bat sign, and that will be kind of that bone over here, and then you have some air over there, and it will be in transverse. It's transverse to the ribs. It's actually technically longitudinal, but it's going to be transverse to the ribs, and it makes a little bit more sense. The bat sign has been described in both veterinary medicine and human medicine. When you see over here, you have those rib shadows, that pleural line over here, some of the parallel areas, reflections that are called the A line, that pleural line over here, and some of the rib shadows over there. You can see it in motion over there. You may see something that people call the long pulse, which is kind of that flickering of that pleural line when the heart is beating. Normal thoracic point of care ultrasound, we're gonna see some curtain sign over here. You can see over there that when the dog is breathing, that you're gonna be able to see some of that thorax and some of the abdomen kind of pointing behind it. So I'm gonna look at it over there, over here on your screen. The glide sign is that kind of gliding, shimmering, people call it different ways, kind of ant on the log, or just that shimmering aspect of that pleural line that you can see over here. And glide sign can be a little bit challenging sometimes to identify. So there are a couple of tricks that you can use to identify the glide sign, and we'll talk about those in a minute as well. All of those things, again, will be normal thoracic point of care ultrasound, and that glide sign, sometimes what we'll do as well is that we'll do an M mode. So that will be one of the motion modes that you have in most of the modern ultrasound machines. And when you are doing it, you should be able to see what people call a seashore sign. What I'll look in those images, you can see M mode over here, is that kind of that granularity at the bottom of the screen. You have some sand over here, you're gonna have a seashore over there, and then the sky on top. And those will be normal. So seashore is normal. The seashore sign on M mode is normal, meaning that there is no air in between the parietal and the visceral pleura, and then there is no pneumothorax. And so that's also when you're not sure about the presence of the glide sign, that's something that you can do. So that's usually what you will see in a kind of a normal point of care ultrasound. When you want to optimize the glide sign, there are a couple of tricks that we do. We're going to decrease the depth a little bit. We can decrease the gain. You can see over here, this is a very video with very decreased gain that kind of highlight the hyperechoic area of the pleura. And then the other one is to put a rib in the middle, so you have what I call the double glide, which is a glide sign on each, and you will be able to see them. So that kind of flickering motion over here is what you want to look at. You can also look ventrally, a little bit more ventrally, fan ventrally, to be able to see that glide a little bit better. The glide can be frustrating, and most of the time it's because people are either too deep or have increased gain. So usually if I really want to see the glide, I'm just going to turn down the gain, make sure that I do have a glide sign, or confirm that I do not have a glide sign, do an M mode if I want to be sure, and then I'm going to crank up back the gain to be able to continue the rest of my scan. The landmarks, again, different protocols, different ways to do it, but most people will have similar landmarks when they are talking about this. One of the landmarks over here in red is that kind of curtain sign. And remember that the diaphragm comes in as an angle. It's not a straight over there. So when you start over here on the top of the chest and you want to go down, you actually may fall into one of the glides. If you go from right over here and you start to go ventrally, then you actually may see that curtain sign. Sorry, I said glide, I mean curtain. You may see that curtain coming up when it doesn't exist over there. Some people follow that curtain sign over here all the way down, and again, that would be a landmark. That blue area over here is the apaxial or sublumbar muscles. And then you've got those cranial aspect over here, which is the thoracic inlet. You can go all the way up to the carotid artery that is cranial to the first rib. And that will be also a landmark that you are kind of the most cranial aspect of the lung. And then the ventral aspect, obviously, will be the ventral lung border and the ventral pleural border over here. This is a still image on the carotid artery that you can see over here. And then that first rib. So this is a cool image. I'm just going to get back my pointer. This is the first rib over here. And this is the start of the pleura. And the carotid artery is over here. So you know that when you are in that area, this is kind of the most cranial aspect. First rib and pleura are right over here. You can put some Doppler as well if you want. And again, I showed it a couple of times, but that will be the other image will be that kind of curtain sign that you can see. And this is a liver, obviously. It's kind of coming in and out, being covered by the pleura every time the dog is taking a breath. So this is the protocol, or one of the protocols that you can use. Again, there are various published out there, and I kind of describe the protocol that I usually do on clinics, which is a 5 to 6 point protocol. Let's go back and let's track back a little bit and remind everybody who joined us about what is point of care ultrasound. So point of care ultrasound is going to be usually a focused, but it doesn't have to be a focused ultrasound examination that is complement clinical examination and is done by the primary clinician, by the one who does the decision. The decisions make the clinical decision. So in theory, you can make a comprehensive point of care ultrasound, a comprehensive ultrasound, and then still call it a point of care ultrasound if you are the doctor making the decision. And it's all a bit of facility terminology, but I like to kind of remind everybody what is point of care ultrasound. Most of the time as a clinician, you're going to use it to answer a clinical question. And we like to think about it as a binary question. Pleural fluid, yes or no, pneumothorax, yes or no, and some of the other abnormalities that you can see. You can also use your ultrasound as the primary clinician to guide the intervention. Most of the time, it's going to be thoracocentesis for the chest, abdominocentesis for the abdomen, lung, FNA, if this is something that you want. It is pretty quick to do it. Usually, it's relatively cheap as long as you have an ultrasound machine, and it's also non-invasive. You don't have to move the dog or the cat to radiology. You don't have to put them in lateral to take those rides. So that works very well on unstable patient in respiratory distress. The disadvantage of point of care ultrasound is you cannot really provide a complete organ evaluation, and that doesn't really remove or replace the need for radiologists, trained ultrasonographers, cardiologists. So you can, think about it as a screening tool in a way as a clinician. And so sometimes I'm gonna look at a patient with my point of care ultrasound. I am lucky enough that I do work in a multi-specialty hospital, so I can do my point of care ultrasound, make some decision based on this, and then get a radiologist or a cardiologist to looking at the images, doing the ultrasound. Um, I have to say that thorax, it's pretty um, kind of, I don't want to say reserved, but it's pretty dominated in a way by emergency clinicians and criticalists. Or some of the radiologists and cardiologists usually don't scan too much thorax. So I think that's one of the nice things with thoracic point of care ultrasound. A lot of the emergency care doctor have been using it. So we use it for patient and stable on triage. We can use it for serial monitoring. Is the patient improving or worsening? And then we're gonna use it for therapeutic or diagnostic intervention. T-focus or pleural and lung ultrasound usually gonna be used for respiratory distress cases. That would be kind of the main reason to do it in clinical practice. You do need an ultrasound machine. This is the one of the machines that we have over here. It's the Mindray M9. And you're usually gonna use a curvilinear probe for doing your scan. You can use a linear, especially if you start to get a little bit more fancy, want to look at the pleural interface. I think that will be something that is interesting. And then we also do have this little hockey stick over there, which is a high frequency linear probe that is very, very crisp images. And that works very well as well for superficial organs like the lungs and the pleural lining. You want alcohol gel, those are pretty classic. Most of the time I'm gonna be in an emergency situation. I usually won't clip the hair, so I'm gonna part the hair, put a little bit of trace of alcohol over there, a line of alcohol there, and then I'm gonna put the gel on the probe. So for the emergency and critical care, that's what I say. I put alcohol on the skin, gel on the probe, and that helps out with that interface and being able to follow this. If the dog is shaved, I think it matters a little bit less. But on an unshaved dog, that's usually what I would say. The nice thing with thoracic point of care ultrasound is that you can do it anywhere, in any position, as long as you've got the machine. Dogs will be, or cats will be standing or lateral recumbency. Those will be perfectly fine. Again, we talked about the different probes. I mentioned it, and I will mention it again. Usually what I would do by convention is that I'm gonna have my marker, my reference point over there towards the head of the dog or cranially, and I'm gonna be in transverse, and usually that will be my starting scan. And you may want to move and rotate, and usually in that case, your reference point over there will be towards you. That will be, again, by convention. The thing that is interesting, so, sometimes people say, who cares and why do I need to do this? Well, I think it's important because when you are respecting those conventions in a way, then the image that you see in front of you on the screen is normal or abnormal. And if you start changing your probe orientation from left to right, from cranial to caudal, or towards you or away from you, when you're scanning on, longitudinal or transverse, those will be kind of registering. Your brain will register it as it's weird, it doesn't make sense to me. If you always do it in the same way, then those images that you can see on the screen will register as normal when you start scanning normal patients, and then you will have your orientation ready to go. It also helpful in emergency situation that when you're gonna grab the probe, if you always do it the same way, you're naturally gonna be able to be in that same position every single time. So I do encourage people to always follow the same path and use the convention because it's going to help you out interpreting those images. thoracic point of care ultrasound, again, if you're looking at pleural and lung, I'm going to stay in the abdominal settings, and I'm going to use a higher frequency for lower penetration of the ultrasound beams. Usually it's going to be anywhere between 3 to 6 centimeter depth, which obviously even in the big dog, you're going to have to change the depth when you go from abdominal point of care ultrasound to a thoracic point of care ultrasound. And the focus point is going to have to be moved on or right below the pleural line. So what do you see? So I used to say you see nothing because there is that kind of air in the lungs, and ultrasounds don't like air. So they're going to bounce back and you don't see anything. And this is the way that I taught. And then until 2011, I believe, when Dr. Lisandro published the first paper on thoracic point of care ultrasound and kind of jump-started the thoracic point of care ultrasound. By that time, I was already done with my residency. So again, I was not really trained in thoracic point of care ultrasound. And I learned from taking classes and courses. And then again, for the past 5 years, I've been involved as well in teaching and training and research in point of care ultrasound. We already talked about a lot of those normal structures, the bat sign that, some people call the gator sign as well, the glide sign that some people call the lung flattening sign, and then the A lines. We talked about all those type of things. This is the next slide is something that is very important to me as well. I call it the image optimization or kind of how to make the image pretty, and I call it the DEFGHI of knobology. And so when you're going to have an image on your screen, you're going to have to decide how to make it prettier. The first thing is going to be the depth. So I'm going to use the interface over there. This is the M9. So this is the one that I used currently the most in our clinical practice. The depth is over there. You're going to change the depth. Sorry. You're going to change the depth to be able to see what you want to see and cover the entire real estate of the screen. That will be one of the things that is important. And then you're going to have the frequency. That's going to be also very important. Depending on the machine, it's going to be a specific frequency range, or either a frequency or frequency range. A lot of the newer machines now have those kind of preset. Pen will be penetration, gen will be general, res will be resolution. And then sometimes you can have the harmonics turned on. So you're going to get the HPen, HGen, and HRes, which will be harmonics with penetration with harmonics, general with harmonics, and then resolution with harmonics as well. In the M9, it's going to show up right over here, and you're going to have those touch buttons to be able to change settings. So I'm probably going to be either on res or HRes because I want to be superficial, so I want a better resolution. F stands for focus point or freeze function. You can see that focus point can move up and down over here. Most of the time in the images that I will show you, they will be on or right below the pleural line. Gain is right over here. You'll have general gain over there and time gain compensation over here. I'm only going to talk about general gain for now, but that will basically turn on the kind of brightness increase or decrease when you do change the gain. H stands for harmonics. Harmonics, that will be that kind of H in that frequency range that you can see over here. The harmonics will basically send out two ultrasound beam with different frequency, and then we'll basically adjust it to make the adjust the beam coming back to the probe and kind of make the image look pretty, for lack of a better word. So I usually gonna have the harmonics on, especially when I'm very superficial. You may want to turn off the harmonics when the dog is very big, but usually I'm gonna have the harmonics on. Other thing that is very important, especially if you're starting in point of care ultrasound and image recording. I used to just get my iPhone out or my phone out and just record the screen, but it's not going to be the best way. So just use that freeze button on the trackpad. You'll have a save button over here. And then at least on the machines that we have, both that P1 function and the P2 function will give you a recording either of the, what happened 6 seconds before or 6 seconds moving forward. And that's something that can be set up on your machine when the rep comes in and deliver the machine. If you already have the machine, I will definitely encourage you to talk to the rep and to see a little bit how you can store, record, and review images. All right, we are talked about convention a little bit, so let's continue on this. All right, so now we're gonna use the same terminology. We're gonna talk about fanning. So fanning is pretty easy. I'm gonna have my probe like this with my reference point like that. And fanning is this, okay? So it's like, oh, it's hot, I'm gonna just fan, and this is how it's gonna work. And then the inverse of fanning is rocking. Rocking is like this. You're gonna move the beam of ultrasound that way, and you're gonna be rocking back and forth, and that would be this way. Then you've got sliding, which is moving that probe up and down, and sweeping, which is moving the probe side to side, like you would sweep with a broomstick. And then obviously you've got pressure, press, relax, and rotate the probe. You have to remember, especially when you are looking using a curvilinear, that this creates, that machine, that probe creates a beam of ultrasound. That it's a sheath of paper that is like a fan that you are using, the kind of old school fan, and that's going to be a sheath of ultrasound that is the thickness of a credit card. So you're going to have to move that beam of ultrasound up, down, left, right, and this is the terminology that we use. I'm not going to talk too much about the next image, but this is remembering cranial, caudal, longitudinal, transverse, those type, proximal, distal. Those will be kind of the terminology we're going to use when we're going to move the probe. So now how I'm going to use that in clinical practice. The first 2 points I already mentioned. Usually it's going to be patient in respiratory distress, and usually I'm going to have a clinical indication or answer a question. The way that I work up my respiratory distress cases in emergency and critical care, I'm using an 8 points anatomical location. And I found it very, very useful. Upper airway obstruction, lower airway. So why is my patient in respiratory distress? Does it have upper airway obstruction or lower airway obstruction, parenchymal disease? That parenchymal disease can be any blood, water, pus, or tissue, any pleural space disease or fluid, any diaphragmatic or abdominal disease pushing onto the chest, any chest wall disease, vascular that everybody forgets, which is PTE, or pulmonary thromboembolism, and what I call the lookalikes or non-respiratory causes of respiratory distress. Those are pretty easy, is that the patient looks like they may be in respiratory distress, but it's not really in respiratory distress. Respiratory distress is a sensation, actually, dyspnea is a sensation that is being showed by a respiratory distress sign. So you need to pick up on that sensation of dyspnea, and sometimes the patient may look like they are in respiratory distress, but they are experiencing a different sensation. One of the nice things that I like about that rule-out list is that upper airway obstruction, lower airway obstruction, and chest roll can be ruled out pretty quickly based on history and physical examination. Chronic coughing, asthmatic cat, striders, laryngeal paralysis, bite wound, stabbing wound, gutshot wound, all of those things, you will be able to rule them out. Your SpO2 is going to be very useful to be able to rule out the lookalikes. SpO2 is above 93. You've got 80% chance that that patient, that dog, is not hypoxemic. So that will give you, this is from Dr. Farrell from UC Davis study, that will give you a good screening tool for this. So point of care ultrasound will be useful to look for pleural space, mainly air and fluid, and can help you out as well with parenchymal disease, maybe some PTE. If you do your abdominal point of care ultrasound as well, you'll be able to get diaphragmatic and abdominal ruled in or ruled out. So this is a very good way to be able to work up that patient that is unstable, that is in respiratory distress, using plus ultrasound or abdominal ultrasound. I'll talk about it a little bit later, but in case I don't have time, that parenchymal disease, that which is unfortunately the most common cause of respiratory distress in dogs and cats, you may not be able to say too much information about the cause, especially at the beginning, maybe with a little bit less experiences, although there have been some papers coming out that may help differentiate between cardiogenic pleural edema and other causes of edema, parenchymal disease on thoracic ultrasound. All right, so I'm going to get started on pleural space diseases. So you have the easiest one, the one that is pretty commonly looked at, is pleural effusion. That is very, very easy. You're going to have a little bit of, so the liquid will show up black on ultrasound, and so you're going to have some pleural effusion over here, separating visceral and parietal pleura, and that usually will be pretty easy to see. Most of the time, it's going to be ventral. You may want to go cranial and caudal to the heart, like we discussed a little bit earlier. You also may want to check the subxiphoid fluid view on abdominal focus to be able to differentiate with the between pleural and pericardial effusion. You may have to be careful of that kind of, there's a little bit of a fat pad, a little bit kind of in the pericardial diaphragmatic triangle that sometimes people mistake as free fluid. That can be a little bit challenging. Question on the chat regarding that pleural effusion. I'm assuming you are referring to the image. So that image, I would call this black over here. That will be a little bit more black than, that tissue over here. This will be the heart tissue. That will be the muscles as well. This can be a patient with high cellular effusion. So that can be a neoplastic effusion, a hemothorax, or pyothorax. And so in that case, it can be showing a little bit more hyperechoic than, let's say, a pure transudate in your point of care ultrasound. The causes, I never bet on any of the effusions except the heart, I guess. But I would encourage tapping and doing a thoracocentesis. Here I've got a list of examples of what that fluid could be. Good question on the chat as well in the Q&A. Because the appearance of the actual effusion can indicate high or low cellularity, but again, I never bet. I always will take a sample. Pneumothorax or air in the pleural space, that can be looked at again with the lack of glide sign. I'm just going to talk a little bit before I play that video, but what you will see, this is a trauma dog hit by a car, and you will see at the beginning of the, actually I'm going to start playing. You can see this is the beginning of the video, and then you can see some B lines, you can see a glide sign over here, and right over there, this is the rib space, the black, and I'm moving one intercostal space caudally, and you will see the changes. Now everything looks still. There is no glide sign. This is a repeat cranial and then caudal. You can see the difference, and that will identify that lack of glide sign in that caudal aspect, which also is called the J point or the lung point, and that kind of show that kind of the most ventral aspect of the pneumothorax. This is from Dr. Boysen and Shalhoub textbook. I'm not going to go over that, but this is a CT images, and you can see depending of where you put the ultrasound, top, bottom, or middle, you're going to see different things. If you are unsure of the lack of glide sign, again, you can use that barcode sign, that M mode. And when you do the M mode, we show the seashore sign a little bit earlier in the normal thorax, but it will look like a barcode or stratospheric sign, which will be multiple horizontal view, horizontal lines. And I'm going to look for the granularity at the bottom of the screen, looking for that sandy beach. If that sandy beach does not exist, correlate with clinical signs, do a blind thoracocentesis, but those will be fair to assume that the dog is a pneumothorax. You actually cannot record it. So this one, I had actually had to record the screen, and you can see over there. I'm going to put the M, and then you can see that kind of stratospheric sign or barcode sign indicating a pneumothorax. So from there, you can just go ahead and perform your thoracocentesis or place your chest tube, depending on the case. My usual way is that I'm going to put it on that most caudal aspect, caudal-dorsal aspect. Look for my glide sign, decrease the depth, decrease the gain, do the M mode, and then I'm just going to move on, confirm with a diagnostic therapeutic type. Other thing, this is that dog with the chest tube placed. Still a little bit of pneumo, but definitely much better than prior. B-line is one of the other things that we're going to talk about. We talked about A-lines, which were normal artifacts, and the B-lines or reverberation artifacts are abnormal. You can see their characteristics on the screen. They come from the pleural line, they move with the lung siding, they go all the way through the skin to the screen, and they represent increased fluid or density in that subpleural interstitium. We call those B-line wet lines. That wetness doesn't mean that it's water, so it can be anything: cardiogenic periedema, non-cardiogenic periedema, any pneumonia, any other kind of, again, artifacts, some fluid into the interstitial parenchyma. You can see over there one of the theories on which, for which how they are created. So people usually talk about acoustic trap, and it can be normal to have up to 3 B lines per hemithorax. So, that's something, it can be normal, it may be abnormal as well. So again, correlate with your clinical signs. This is a cool video looking at B lines. This is during a cardiac point of care ultrasound. You can see that this is cardiac setting. and you can see some B lines, maybe a little bit of an R large AO ratio, but I'm not going to talk too much about that. This is a still image as well. Sorry, this is a still image on the right, looking at those P lines. Couple of other example. This is using a hockey stick, that high frequency probe that I talked about. You can see the images are very crisp on those B lines over here, and then other video looking again, some B line, a little bit of shred as well, and coalescent B lines. This is coalescent B line video over here, pretty severe wet lines on that patient as well. Just making a comment, this is probably just for, you know, the know that they exist, the different lines, the Z lines, the E line, the I line. So the Z lines are pretty common in normal animals. When I do some teaching, I do see those Z line pretty commonly. And then you've got those I lines as well that can be normal or can be pathological. The main difference between the I line and then the B line is that the I line do not cover all the way into the screen. And then that can be a marker of fibrosis, or at least in people it is. There is no data that I know of in dogs and cats. I talked about shred sign. Those would be C line or shred signs. C lines are vertical artifacts generated by kind of a tissue-air interface or inside a consolidated lung. So they're going to look over here. You can see over there the kind of those C lines are being created into that through that lung parenchyma. And the other one is that shred sign or fractal sign that is considered lung consolidation. And it looks very irregular or shredded. That's kind of where the name comes from. And then it's usually going to be indication of a consolidated lung lobe or pneumonia. There is a still image over here of that shred sign that you can see with a little bit of C line, and a video over here, a respiratory distress dog with pneumonia. It's very tachypneic. Then you can see both B line, C line, and shred signs are here. Now that we're done, we kind of go, I've got a couple of slides on kind of a little bit more unusual things. I'm going to go pretty quickly on those. And those are not images that are acquired because I've not seen them. So a lot of them come from different publications. Lung lobe torsion, you can see this is for a paper that was published a little bit earlier this year. There's a very good paper from Andrea, and you can see a lung lobe torsion over there with kind of that an apex, and so that would be consistent with the lung lobe torsion. Pulmonary thromboembolism as well can be seen. A wedge sign has been described a few years ago by Dr. Lissandro on his team as well. You can see that picture from his publication. Couple of things about pulmonary fibrosis. We talked about the eye lines. There's no data that I know of in dogs and cats, but you can see some of those changes in that subpleural line, which I think will be something that will be interesting to look in the future. We do have some studies going on at CSU looking in that pleural and pleural line. Pulmonary neoplasia, you can see over here, and this is the dog with a mass over here that you can see in the lungs and some B lines. So those, some of those, you will be able to see them on ultrasound as well. This is a really cool video using that hockey stick high frequency probe. You can see tons of near little nodules with hyperechoic shadowing over there. This dog was an older dog in respiratory distress. You can see the pulmonary neoplasia that we confirm on rats, but we already had a very, very high index of suspicion looking at the point of care ultrasound. Again, normal at one site doesn't mean that it's normal everywhere. So you're going to have to scan the entire chest and scan multiple times. The fluid type, you're going to have to do a thoracentesis. And I'm usually going to use POCUS personally as a screening test. I still rely on chest rads. I think it's very important to store your images as well. That's one of the main thing that I would say. The rides, you have an image, you can put it in the medical record. If you don't record your point of care ultrasound images, then it doesn't mean too much. So very important to include that in the medical record as well. And it's a practical skill. So you need to practice. You need to learn about it. That's how I learn myself. I took classes and scanned. And again, that importance of convention, tricking your brain to see what's normal, and store those images. Shelley is asking about the A lines versus the B line. So let's just go over. I may have to go all the way back to the first slide. The B lines is going to be those vertical artifacts that people call the lung rockets. They're going to be over here. Let me grab my laser pointer over there. The B line are vertical artifact that is hyperechoic. The A lines are horizontal artifact that is usually going to be discontinuous, and those will be normal for those cases. I can go back. I don't want to take too much time because I know that Jennifer has a couple of things to talk about. I'm just gonna go real quick over here on this image, and hopefully you will be able to see those vertical artifacts over here on that right side that you can see at the end will be the A line. Difference between shred sign and pulmonary nodules. The shred signs will usually be very shredded. You will have a very, very irregular margin, when the nodules are going to be a lot more round and a lot more kind of crisp, and may or may not come with a hyperechoic rim. I'm going to stop sharing. And I can answer all the questions if people have other questions. You're welcome.
Anyone else has any questions? Dr. G, great as always. Can you just tell me, what do you feel like, how many times did you scan a normal patient to start recognizing the abnormal?
It's a good question. I mean, I'm lucky enough that we do have a lot of cases, and I did scan a lot of normals before. So I think if you start with scanning, I would say around 5 normals, and then you're probably going to start around 10 abnormals, you already have a good foundation. And I think the way I learned it, which is I think it's going to be the case of, most people, who have not been graduated in the past 5 years, you learn by layers. So I recognize normal, and then I starting to recognize B lines, and then I was starting to recognize shred signs, and I worked a lot with the M mode as well. I like those type of things. So I just I forced myself to M mode everybody. And then the thing that really put me to the next level is that nomology, that kind of image optimization. What is the power of that ultrasound machine, and how they can help you, different probes. And that's how I took off priority for the past, 2 to 3 years, how I kind of exponentially learn on how to use the machine.
Well, that's a great answer. So I just encourage everyone to just practice. The more you use your transducer, the more you use your ultrasound, the more you understand it, the better medicine you will have. So thank you again so much for all of your time. I really appreciate it. And Mindray Animal also appreciates you. We're all very lucky to have doctors like you in our lives. Please follow our social media. By the way, CE certificates will be emailed to all the attendees that are on here, and give us just a little bit of time. That will come from Colorado State University within the next week or so. So be patient on that, or anybody that also watches the recording can also get the CE. Again, give them a little time to get that processed. And just please register for our next two events. Follow our social media. We're giving away some Mindray Animal Medical brick sets, which are super fun. And look forward to seeing you next time. Thank you so much.
Thank you very much. Thank you, Jennifer, for the kind words, and thank you everyone for attending. I really appreciate it.